Good morning and welcome. I'm Richard Oehler, Associate Professor of Medicine with the Division of Infectious Diseases and International Medicine at the University of South Florida College of Medicine. And this morning I'm going to be giving an update on HIV in 2010. It's amazing to think that we are now entering our fourth decade of dealing with this incredible infectious disease, which has occupied so much of our research and therapeutic efforts over the last now 3+ decades. These are some of the topics we're going to be discussing today, with a focus on epidemiology, therapies both new and old, and we'll touch a little bit on the issue of resistance as it applies to therapy, prevention, and prophylaxis for HIV exposure. As many of us know, HIV is a three-phased disorder with an acute phase, what's known as an asymptomatic phase, and the phase hallmarked by a progressive decline in the immune system, the incidence of opportunistic infections, and the phase with the highest complications, namely the phase of clinical AIDS. The acute phase is hallmarked by the onset of a detectable plasma viral load following acute exposure. This is paralleled by an increase in the production of so-called HIV cytotoxic lymphocytes. At the same time, there is an acute decline in the CD4 count with the onset of viremia. This is marked by a nadir in the T cell count, initial nadir, with a recovery with the production of HIV antibodies. The production of significant HIV antibodies and a peak in the HIV cytotoxic lymphocytes marks the exit from the acute phase to the second or asymptomatic phase. During this period of time, the T cell count is relatively stable with a slight decline. The plasma viral load is also stable. This period of time is the phase in HIV infection where most patients essentially do not experience very many symptoms until the end of the asymptomatic phase, where the T cell count approximates 200. Following the CD4 count reaching a decline to 200, the degree of opportunistic infections increase. There is a progressive increase in the plasma viral load if HIV therapy is not instituted, and the proportion of HIV cytotoxic lymphocytes gradually decreases until the end of clinical AIDS, ultimately death. And this death horizon, so to speak, has been extended profoundly in patients on therapy. And in recent years, it's been recognized that HIV positive patients can literally lead a normal lifespan with proper therapy. So as the phrase goes, people are living with HIV, they're not dying with HIV, and that has been one of the great successes of our efforts in combating the HIV/AIDS epidemic. But we still have our hands, our job cut out for us, and our hands full with what we have to do. HIV infection globally peaked at close to 39 million approximately 2 to 3 years ago in 2004 to 2005. And we've seen a decrease in the number of people living with HIV for several different reasons, because perhaps because of efforts related to prevention, perhaps because there's been some increased mortality among HIV patients in some of the harder hit areas of the world, and for other factors as well. Globally, HIV prevalence is highest in several areas of the world, namely the former Soviet Union, Southeast Asia, and to a certain extent the Americas, but particularly in sub-Saharan Africa, where rates are among the highest in the world. Looking at this another way, where we exaggerate geography based on the prevalence of HIV in the 15 to 49 year age group, you can see the vast preponderance of HIV infections in sub-Saharan Africa, but also in India, Southeast Asia, the Americas, and Western Europe as well. About 2/3 of all infections worldwide are in sub-Saharan Africa, a tremendous quantity, and sub-Saharan Africa sees about 1/3 of all new infections as well. So we have about 22 million out of the 33 million cases in sub-Saharan Africa, but significant quantities of HIV also found in South and Southeast Asia, Eastern Europe and Central Asia, and the Americas. In Florida, where I practice, we are really in the back door of the Caribbean, which is which is notable when you consider that the Caribbean has the second highest adult prevalence of HIV in the world, about 1.1%, right behind sub-Saharan Africa. So there's no question that we in Florida get some of the overlap of the Caribbean. We need to be aware of the relationship between Caribbean origin and HIV prevalence. We still see some 7,400 new HIV infections a day, and 50% of these are women, and 45% are among young people ages 15 to 24. Southern Africa has some of the highest HIV rates, as I talked about. There have been some notable successes, particularly places like Zimbabwe, and some setbacks in others like Mozambique. Our efforts in HIV in Southern Africa continue. How significant is the impact of HIV in Southern Africa? It's huge when you consider that life expectancy has been increasing in every other area of the world in the last 50 years, with the exception of Southern Africa, where it's been declining really since about 1990 due to HIV/AIDS. There are many more resources available for AIDS treatment and research in 2010 than there were in, let's say, 1987, logarithmically more, with the benefit of public funding and private philanthropy, people such as the Gates Foundation, also U.S. funding through PEPFAR and other funds as well. So the main drivers of the HIV epidemic by region vary, principally in places like sub-Saharan Africa and Asia. Heterosexual transmission is a major factor. In Asia, also IV drug abusers and men who have sex with men. Eastern Europe and Central Asia, primarily IV drug abusers. In the Western countries, the combination of men who have sex with men and IV drug abusers. HIV/AIDS continues to be overwhelmingly represented in the African American community, more so than the white and Hispanic or Latino community, and this is important to consider when we want to target our prevention efforts. In North America, AIDS cases and AIDS-related deaths have been relatively stable in recent years. We have more people living with HIV on antiretroviral therapy, but we're also seeing younger gay and bisexual men encountering HIV. These are men who now, in an epidemic that is approaching 30 years, encompasses a lot of people who were not around at the beginning of the HIV epidemic and may not be aware of the risk factors for acquiring HIV, or may have the false sense of security that if they do acquire HIV, that it's a manageable condition. Whereas HIV was once really confined to gay and bisexual men, and IV drug abusers and among people who had contaminated blood products. As anticipated, we're seeing more of a breakout of HIV infection to communities of color as it penetrates the heterosexual community, particularly among women. In a slide that did not display properly in this presentation, we saw that the primary risk factor for HIV among women is in heterosexual contact with a man, whereas in men, homosexual contact, contact among men who have sex with men, is the leading risk factor. Florida has a major burden of HIV across among U.S. states. We're number 1 in heterosexually acquired HIV. We're number 2 in pediatric cases of AIDS, and we're number 3 in overall cases, behind New York and California. If you look at HIV cases by county of residence, it's really among the densely populated urban areas where HIV cases predominate. And this is no surprise, because in these areas, some of the higher risk groups, urban communities, gay, bisexual men, and IV drug abusers would tend to predominate more so than in some more rural areas of Florida. Among the age group 25 to 44, HIV/AIDS is the 5th leading cause of death among all Floridians, and the leading cause of death among the African American community, both men and women. But HIV continues to be predominantly sexually acquired infection, even among female-to-female contact, where transmission has long been documented. Contaminated blood and blood products, not as much of a factor anymore, really, since strict testing of the blood supply, and a change in where we obtain blood donations was made more than 10 years ago. We still see HIV transmitted between IV drug abusers, and contaminated needles and syringes, and vertical transmission from mother to child has been greatly reduced as a result of peripartum prophylaxis. Women are among the fastest growing groups for HIV, and this leads to an increase in the frequency and severity of GYN disorders, many of which are CDC HIV associated conditions. We always need to remember the increased risk of cervical cancer among AIDS and HIV infected women, and screen appropriately. For maternal fetal transmission, transmission can occur both in utero, during delivery, which is the most common way in this country, and in breastfeeding, which is discouraged in Western countries but still encouraged in places like Africa, which have a much lower ability to provide nutrition outside of breastfeeding. So in those areas it is encouraged. The risk of vertical transmission is much higher in developing countries where women breastfeed. In this country, the risk has been estimated at 25%, but it can be greatly reduced by peripartum prophylaxis. Most HIV transmission in non-breastfeeding women occurs in the intrapartum period. We all remember the landmark ACTG 076 study, which proved the benefit of prepartum and peripartum AZT in causing a 3-fold risk reduction in transmitting HIV vertically to a newborn. Nowadays, standard therapy, with a couple of notable exceptions, is recommended prior to delivery with IV AZT administered during the birth process. How do you handle someone with HIV who is pregnant to reduce the incidence of vertical transmission? If they're already on antiretrovirals, it's recommended that they continue. Remember, of course, that some antiretrovirals like efavirenz are not recommended during pregnancy, especially during the first trimester. If they're not on antiretroviral therapy, it's recommended that it be initiated after the first trimester and the second or third trimester. the decision of whether or not to obtain a cesarean section is controversial and really should be individualized between a expectant mother and her obstetrician, but it's been thought that in some cases it can have a substantial reduce in the risk of peripartum transmission. Now, what about the viral load and T cell count? Many of you may have heard the analogy that the viral load and CD4 count can be thought about as a speeding train going down a long track with a cliff at the end. And the viral load is the speed at which the train is heading towards the cliff, and the CD4 count at any given moment is the distance from where the train is to the abyss. We use CD4 count, of course, to define the onset of clinical AIDS, which is defined as a CD4 count of less than 200 or a CD4 percentage of less than 14. How do we make an HIV diagnosis? Of course, with an HIV antibody test. We usually screen with an ELISA test and confirm with a Western blot. Of course, we never want to confirm or screen someone for HIV with a similar test such as a CD4 test. It's not recommended. Again, consent is always necessary for HIV, although what we will soon see is that the type of consent is changing to make things more convenient and hopefully to broaden the list of eligible people who can be screened with an HIV test. Now, when HIV was first an early diagnosis, there was a great stigma, and many persons would even be denied treatment, as credible as it seems today, or would be denied access to services. They were perhaps their care was compromised because they were thought to be highly contagious, and revealing a person's HIV status was thought as something that no one would ever do. And we all remember the celebrities in the 1980s who were never identified as dying of HIV until after their death, some years later. So for this fact, public agencies adopted a very confidential policy about HIV screening, and this included informed consent, pre- and post-test counseling, and definitely a lengthy consent form along with counseling was thought to hinder the number of people who could be HIV tested. So in 2006, the MMWR and the CDC changed their recommendations for HIV testing to what is known as opt-out screening. This type of screening is very similar to the way we get any other medical test. In other words, to document that the patient it's been mentioned that the test is done, that verbal consent has been obtained, and that the patient has a right to decline the screening if they don't want it, but a written consent form where the patient has to be read all the lengthy issues with testing is not necessarily any longer required. If I can put this verbatim, the CDC wrote, HIV screening is recommended for patients in all healthcare settings after the patient is notified that testing will be performed unless the patient declines. So for example, when you order a CT scan on a patient, you tell the patient, we're going to get a CT scan. The patient has the option to opt out of this or to refuse the test, but unless the patient refuses, the test is performed. The feeling was that this type of consent was appropriate for HIV to allow us to encompass the broadest number of people to be tested. The document also says separate written consent for HIV testing should not be required. General consent for medical care should be considered sufficient to encompass consent for HIV testing. Prevention counseling should not be required with HIV diagnostic testing or as part of a screening program in healthcare settings. Now in Florida, where I practice, there's a definite written policy in the state code about HIV testing. I also practice in the U.S. Department of Veterans Affairs VA system, where testing guidelines have also recently changed, so that opt-out testing is the standard. But it took several years after the CDC document for this policy to be adopted. But what are the legal issues in Florida for those of you in the audience who are listening to this presentation from my state? Well, pre-test counseling is recommended still, but it's no longer legally required in Florida except in pregnancy. Informed consent is still legally necessary for HIV testing, except in limited situations such as occupational exposure and court orders. However, consent is no longer necessary to be in writing. So I can approach a patient and say, I'd like to obtain an HIV test on you. If the patient agrees, that is the only legal requirement that is necessary in the state of Florida, with the exception of the fact that that you have to document that you obtain consent. So you no longer need a consent form. You just need to say in the medical record, I have consented the patient for HIV, and he agrees, and then the test can be performed. Now in an occupational exposure, let's say where the blood is already available in the lab, maybe the patient is a cardiac surgery patient who is unable to give consent. Legally, consent is not necessary in occupational exposures. The subject patient can be tested for HIV and their status can be documented. Also in court orders, this informed consent is not necessary. If a person is HIV positive, post-test counseling is still required, but it no longer needs to be legally mandated to be face-to-face, although this is recommended. For those of you who have further questions about this, there is a link to the State of Florida website where this information is spelled out verbatim. What are the necessary components of pre-test counseling? I've shown them here in the state of Florida, and they are extensive, but they can be helpful to someone in understanding why they're being HIV tested. Post-test counseling, also listed here. Again, this is required but no longer need to be face-to-face. And the pre-test counseling, as I've said, is no longer required but is recommended. According to the CDC, there are now about 6 rapid HIV antibody testing methods. The latest version is the Clearview test, which has a longer shelf life. All of these now are second or third generation or even higher and are highly accurate. However, it is recommended if you get a positive test that you always confirm it with a standard test. The decision on when to start antiretroviral therapy has been kind of a pendulum that has swung back and forth over the years. The pendulum now is swinging more towards treating patients sooner. So when do you initiate antiretroviral therapy? Well, if someone is having an acute HIV seroconversion, it's felt that you can sometimes start antiretroviral therapy for several weeks, not permanently, but start it for several weeks, and it may abort the typical immune system response for HIV that produces chronic infection. So treatment in the situation of acute HIV seroconversion can be helpful. If a patient is symptomatic, regardless of their T-cell counter viral load, initiation of antiretroviral therapy is recommended. If they're asymptomatic, it's a matter of what their T-cell count is, what their viral load count is, and also the patient's willingness to start treatment. That is tremendously important. Evaluation of the positive patient begins with a good, thorough history and physical examination focused on several different important organ systems. along with screening labs including serology for toxoplasmosis, syphilis, hepatitis, and in some cases CMV. This is from Scott Hammer's document in Journal of American Medical Association in 2008 as far as when to start therapy. Again, if you look at the guidelines globally, all of them are in agreement that therapy should be started in patients with a certainly be started in patients with a T cell count of less than 200. And it's recommended that now that if someone has a CD4 count of greater than 350, if they're asymptomatic, that antiretroviral therapy should be strongly considered, and should be considered even in patients with T cell counts of greater than 500. So if you look at the global guidelines, they are in agreement that now that the CD4 count of 350 or less is really the hallmark now that it's accepted that antiretroviral therapy should be strongly considered. And those with a T cell count of greater than 500 even are now considered potential candidates. There are a variety of different HIV combination therapies available. Our goal is to suppress the virus as much as possible while we preserve immune function, reduce HIV morbidity, prevent opportunistic infections, and preserve future treatment options. Research into HIV therapeutics has, perhaps more than any other condition, resulted in an incredibly widely diverse series of different drugs. The nucleoside and nucleotide reverse transcriptase inhibitors, of course, were among the earliest, followed by protease inhibitors. But nowadays we also have HIV entry inhibitors. We have non-nucleoside reverse transcriptase inhibitors, and the newer drugs, integrase inhibitors. In addition, a maturation inhibitor may be available in the near future. There are some 23 or 24 currently available antiretroviral medications as listed here, and it can be very difficult to keep up with these unless you really work with HIV positive patients. And there are new ones still in the pipeline. These include a new NNRTI and NRTIs, a new HIV entry inhibitor, Vicroviroc, a new integrase inhibitor, Raltegravir, and a co-formulation or quad pill containing Truvada, Raltegravir, and Glaxo's proprietary boosting agent, GS 9530. So this offers promise of a single therapy, a single pill with all appropriate drugs for patients who are perhaps treatment experienced. Which combination is best? That's really the question, and it can certainly be very confusing to decide. The updated guidelines for the use of antiretroviral agents in HIV-infected adults and adolescents was recently updated on December the 1st of this month by HHS, and the key updates for 2009 included an emphasis on genotype testing over phenotype testing because of cost issues and availability. The HHS panel is recommending even earlier initiation of antiretroviral therapy, even as much to say if you have a CD4 count of between 350 to 500, you should strongly consider starting heart therapy, and if your CD4 count is greater than 500, to even consider it. Raltegravir or Icentris has been added to preferred therapy, first-line therapy, due to a recent clinical trial showing it was equivalent, or I should say non-inferior, I believe, to efavirenz in combination with two nucleoside agents. Because of possible cardiovascular and durability considerations, Lopinavir ritonavir has now been moved to alternative therapy in the guidelines, and the guidelines recommend earlier consideration of the Trophile assay if an HIV entry inhibitor is being considered. There are advantages of when to start antiretroviral therapy. Of course, somebody who's symptomatic at any age should be begun, as I said before. But earlier therapy may keep patients healthier longer. It may prevent transmission of resistant virus. It may improve overall clinical outcomes and prevent opportunistic infections. On the other hand, it's more costly. There are an increased risk of resistance with poor compliance. It increases the side effect profile of therapy, and the argument can be made, potentially compromise our options for the future if we run into problems with current medication combinations and we have to decide on choosing a separate agent. Again, these are indications for initiating antiretroviral therapy in patients with chronic infection. Pregnant women, again, and those with HIV-associated neuropathy should also receive some special consideration regarding treatment selection and timing of antiretroviral therapy. Again, CD4 count of greater than 350, we need to consider antiretroviral therapy as well. These are the initial treatment recommendations for treatment-naive patients in the new HHS guidelines. Our three options are the combination of Truvada with either efavirenz, boosted atazanavir, darunavir, or raltegravir. Alternatives to this regimen include the PIs and NNRTIs shown here. Particular note, Lopinavir ritonavir listed as an alternative agent where it was a preferred agent in the previous guidelines. Alternative NRTIs, if you can't use Truvada, include abacavir plus 3-TC, DDI plus 3-TC, or zidovudine plus 3-TC. Adverse effects of drug therapy is common. Remember that many of these drugs can have interactions with the statins and other H2 blockers. Adherence is very important. Studies show that a patient needs to be compliant at least 95% of the time to get the greatest durability of their response. Opportunistic infections are much less common nowadays. We are just not seeing them, and it even begs the question of whether patients can be aggressively weaned off of their PCP therapy sooner as the risk has decreased so much. Metabolic complications include lipodystrophy and lipoatrophy. This is a loss of subcutaneous fat, particularly on the dorsal hump, where patients can present with a fat pad. This is fat accumulation in a gentleman with HIV. Lipoatrophy involves wasting of the skin around the mouth, which can be severely debilitating for these patients, preventing them from socializing with their friends and colleagues. There really is no cure for lipodystrophy. Sometimes anabolic steroids or human growth hormone or lipid-lowering agents may show some promise, although this has not certainly been based on any sort of clinical trial. Resistance and adherence, still very important. And when we do check for resistance, we usually order a HIV genotype. The phenotype is more analogous to doing drug susceptibility testing, and it doesn't have as much of a role certainly in treatment-naive patients or patients in first failure. Virtual phenotype is a way for the computer to predict a phenotype based on the genetic pattern. When should we perform antiretroviral resistance testing? Well, if someone has virologic failure during therapy, if they're not being adequately suppressed, if they have acute HIV infection or chronic HIV infection, it's recommended to check a genotype. If someone has a viral load count of less than 500, or if they've just discontinued their drugs, a resistance test is not recommended. Just to mention these two very important monitoring studies, specifically the HLA B5701 test, which is now recommended for screening purposes in any patient who could be considered for abacavir. It's really important to get this test. Although we treated a great many patients with abacavir prior to the availability of this test, the guidelines now suggest that it needs to be ordered, and theoretically you may miss a case of abacavir hypersensitivity. The Trophile assay should be considered, of course, in anyone who is a candidate for an HIV entry inhibitor such as Maraviroc. We know that prevention is the best way of avoiding HIV, and this includes healthcare workers, where barrier precautions are very important. Also, if a patient is already HIV positive, they can be a transmission point to other people, and they need to understand the significance of certain behaviors for HIV transmission if they're positive. We still continue to emphasize safer sex messages, including barrier precautions and so forth. Now, the last CDC post-exposure prophylaxis guidelines were released in 2005, and they recommend relatively rapid initiation of therapy for 4 weeks, and the common regimens still continue to be either Combivir or Truvada plus or minus efavirenz or Lopinavir or ritonavir. How about non-occupational post-exposure prophylaxis? Well, this is easily one of the most controversial types of prophylaxis, because certain camps feel that this may encourage high-risk sexual behavior, because patients know that if they have a high-risk exposure, they can just go to non-occupational PEP. But there's more mixed sort of advantages and disadvantages with this. For one thing, it's very costly. It has to be initiated within a short time after exposure, and it's not known what its effects on behavior are. Well, I've talked a lot about HIV, and certainly no one can spend an hour and cover this infection comprehensively. If you wish to learn more, I'd strongly recommend the aidsinfo.nih.gov website, which has a variety of information on HIV therapy, diagnosis, and management. There are many other websites for HIV infection, which I've reproduced here. And I'll go ahead and stop there. Thank you all very much, and I hope you've enjoyed this presentation. Thank you.